on April 8th will address racial equity issues. So thank you all for being here today. Before I continue, Ellen, are there any logistical issues that we need to mention to folks who've joined us for the webinar today?
Hi, everyone. You will see the Q&A feature available on your Zoom. If you have any questions for the speakers as the session goes on, please go ahead and drop your question and answers in there. You can also use the chat feature, but we're going to be pulling questions for that section from the Q&A function. So if you have something specific for them, please place it in there. Thank you all so much for being with us.
Thank you very much, Ellen. Well, I'm very pleased to have a wonderful lineup of speakers today. I'm going to just briefly introduce all three of them at the beginning, and then each of them will speak for about 15 minutes, and then we'll leave about 10 minutes at the end for Q&A. So our first speaker, Keith Humphreys, is the Esther Ting Memorial Professor at Stanford University and a former White House drug policy advisor in both the Bush and Obama administrations. He's testified to Congress on multiple occasions and has served as a member of the White House Commission on Drug-Free Communities, the Veterans Administration National Mental Health Task Force, and the National Advisory Council of the U.S. Substance Abuse and Mental Health Services Administration. Dr. Humphreys will be followed by Dr. Steve Wyatt. He is a board-certified psychiatrist with an additional certification in addiction psychiatry. Steve is an adjunct professor of psychiatry at the University of North Carolina and the current chairman of the North Carolina Psychiatric Association's Addiction Psychiatry Committee. And then the third speaker will be Eric Sweden. He served for 21 years with the Raleigh Police Department, where he retired last year as a lieutenant. Eric now works as a DWI program specialist at the North Carolina Department of Health and Human Services. He is a DWI detection and standardized field sobriety test instructor, as well as a drug evaluation and classification program instructor through the National Highway Traffic Safety Administration and the International Association of Chiefs of Police. And on top of all that is a state certified and nationally registered critical care paramedic. So without further ado, I will turn things over to Keith Humphreys. Keith, take it away.
Thanks very much, Stephen. Very nice to visit with all of you. Could we have my slides put up, please? All righty, that looks great. So I'm going to talk about what medical cannabis, or as some people call it marijuana, it's called in law, but in science we usually say cannabis, what it can do and what it can't do. We advance, please. Thank you. So first, disclosures. I want you to know I don't have any past, current, or planned financial connections to the cannabis industry. I say that because it's important. I also just some words to the wise is you should be curious about that with everyone who gives you advice on this issue. There's a lot of money on the table and you have a right to know where people are coming from. I also want to say I have no interest in telling you how to vote. I do care about North Carolina. My parents live there. My aunt lives there. My sister went to college there, met her husband there, spent a lot of time in your beautiful state. And I really do like it, but I don't live there. You will live under whatever laws you pass. I will not. So I'm certainly not going to tell you should do this or you shouldn't do that. I really see my role here as telling you what the evidence is so that you can know how to get whatever it is that you decide democratically that you want to do. Because the worst thing that can happen, and it has happened in this area, is people pass a policy hoping for one thing and then they get the opposite of what they wanted. So that's the spirit I'm going to be speaking with you today. Could we go to the next slide, please? Thank you. So there's benefits and there's risks to medical cannabis, like there are to most drugs. In general, the way we approve medications for use in the United States, like when you go to your doctor and you're prescribed something, is that they have to go through a randomized clinical trial, which is a rigorous experiment. They have to have studies showing that they're safe generally, and that they have a therapeutic effect, that they work for some condition. And these are tightly controlled and very carefully monitored. Medical cannabis, not entirely, but mostly has not been approved and evaluated that way. A lot of it's come in by people just voting to have it in. A lot of it's been based on individual experience. A lot of it's been based on correlations, but not necessarily experiments. So the data is a lot weaker relative to what it would be like how an antibiotic comes in. You should know that coming in. Also need to know that there are public health considerations when we understand what works. So, one person could have a story that, let's say, they had a condition and they used a lot of cannabis and they feel much better and they very want to speak about that. And that could be true for them. But when you approve a medication, it does in fact go out to lots of other people. So you also have to think about not just would anyone at all benefit ever, but would anyone be harmed? And that's particularly important with controlled substances because we know, look at opioids, we know they're useful. We also know that some people are harmed by them. So we have to think about who might be harmed as well as who might be helped. Next slide, please. So we do have some cannabis-based medicines already that have been very rigorously tested and which work and which doctors can use in either our country or other countries. There's a medication called Marinol. It's a synthetic THC, which is used for chemotherapy-induced nausea, approved by FDA. Epidiolex is just recently approved. I worked on that a bit in our state, California, but it's a CBD-based medication for various types of seizure disorders of Dravet syndrome. And then in the US, in Canada and Britain, and probably some in the US, there's a medication called Sativex, which is a mixture of THC and THC, which is used for spasticity and multiple sclerosis. And all these things work. It's great. It's great if we get medications out of cannabis. We will probably get more. It's an interesting plant, has a lot of different components to it. So there's no reason to be afraid of cannabis-based medications. I mean, just, there are other plants that have generated, medication, salicylic acid, which is, aspirin exists in nature, opioid exists in nature. So it's just part of the process by which, we learn through science how to turn things into medicines. And that's certainly good. Next slide, please. Now, I do want to say at the same time, we've had a lot of promises made about the effects of cannabis that are not true, that have been lucrative for some people, but have not actually been based on facts. So for example, WeedMax put billboards like this up all over the country, saying that if you legalize marijuana recreationally or medically, you would reverse the opioid crisis. And this was based on just a correlational state level study that early on, some of the early legalizing states had lower than expected opioid deaths. And we would not approve any other medication this way. I mean, just to give you an example, states where people eat less ice cream have fewer drownings. All right, that's a correlation. But that's because, if you're a coastal state where it's hot, people go swimming a lot, they're more likely to drown, but they're also more likely to eat ice cream. Doesn't mean that ice cream protects or causes drowning. But this is the kind of data that was out there and has been pushed very aggressively around the country. Next slide, please. As it turned out, by the way, a research group, the team I was a part of, led by Dr. Chelsea Shover, went back and looked at this particular correlation. The dark black line in the middle of the dotted lines is the best estimate of the correlation between opioid overdoses and the legalization of medical cannabis. And when the initial study was done, which is 2009, it was below the 0 point, meaning it was a negative correlation. But over time, it's actually turned positive. So more recently, legalization states have higher rates of opioid overdose. Now, Dr. Shover is a serious scientist, so she didn't say, aha, I've now proved that cannabis causes opioid overdoses. Nothing so silly as that. Instead, just saying correlations at the state level, they don't mean anything. And we would certainly not approve any other medication on that basis. Next slide, please. PTSD is another area where some very strong claims have been made. As mentioned, I've done a lot of work in the VA. I'm from a family of veterans. I care about the veteran health very much. But this is the most recent meta-analysis of military veterans' experience with PTSD and cannabis. And the conclusion there, I'll just read it, is the balance of the evidence associated cannabis use with negative health outcomes with consistent positive associations with other substance use, psychiatric disorders, and self-harm, suicidality. So that's another area where there's been a lot of promises made, but the evidence is just not there. Next slide, please. Some other things that have been advertised by cannabis producers include that cannabis will cure COVID-19, that it will cure heroin addiction. You should stop taking, there's been advertisements, you should stop taking Suboxone, which is an FDA-approved medication, and take cannabis instead, that you don't need insulin, you need cannabis for diabetes, that it can cure cancer. I was really disturbed to hear from an oncology friend of some patients dropping out of chemotherapy because they've heard that CBD oil will remove their cancer. And then in prenatal health, there's been a couple studies done that if a woman calls what's called a bud tender in California and asks about, cramping or other sort of unpleasant experiences during pregnancy, that about 80% of the time they're recommended to smoke cannabis through their pregnancy, which most likely harms the developing fetus cognitively. And this is a case where these are put forward as if they were medicine, but no one has ever made that test. But at the same time, a bud tender is not liable for the advice they give medically. If a doctor gives really bad advice, they could lose their license, but a bud tender isn't licensed. On to the next one, please. So the key point I would make, how do you differentiate the hype from what is real, and how do you make a system that is safe, is just to remember that medicine has, go back please, thanks. Medicine has status and trust because of its rigorous standards. So if we want to have a good medical cannabis system where we get medications that work, we want to have the same standards we would for other types of medicine. It's kind of like if you're a parent and you have an adolescent child, you may have had the experience of hearing an adolescent say, I want all the rights and privileges of adulthood, but I don't want the responsibility. But rights, privileges, and responsibilities should go together. So if you go forward, you want to make sure you have standards you would impose on other areas of medicine so that people are safe. Go to the next slide, please. Some people feel that even if there's not a lot of evidence for some of the medical cannabis claims, that it's a good way to get recreational legalization through the back door. And this was actually done in California, where medical cannabis was passed, and then the criteria for getting it became so loose that pretty much anyone could get cannabis through the medical system. And some people would argue that, well, look, legalization of cannabis promotes social justice, so it's okay to, that deception is all right. It's okay to say it's medical, even though you're really doing backdoor legalization. So I've just asked you to consider, if that's your view, to remember that if we create a medical system that's really faux medical, we are telling sick people that some stuff is medical that may not be. And I don't think that is actually just. The second point is that form of legalization will probably increase racial and economic disparities in arrests. And the reason for that is, if you have a medical system that's a nod in the wink recreational system, the people who are most likely to have the wherewithal to get to a doctor, get the right paperwork, get the card, are people who are better off, people who have more education, more income. That might be easier for white individuals and people of color. And so you're really legalizing for the better off people, and that can make disparities worse rather than better. That's a risk of doing this type of sort of backdoor recreational legalization through the medical system. Next one, please. I would point out, some would say, but arrests are terrible. They feel strongly that they do more harm than good. I just point out there's a simpler way than creating a medical system, if that's the main concern, which is just decriminalizing the possession of cannabis. So in California, we passed a law that if you had an ounce of cannabis or less, it would no longer be a misdemeanor. It just became a civil infraction, like a ticket, like a parking ticket. And there was an 86% drop in those arrests for both adults and youth. So there is a way, if that's the goal, there is a sensible way forward. You don't need to go through all the rigmarole of establishing a medical system for that. You could actually just decide to do this and have a pretty dramatic change pretty quickly. Next slide, please. So another goal a lot of people have is, equity. If they want to create an industry, they want to make sure that, that all groups can participate equally. So just say one point about that is that if you go forward with any type of legalization, medical or recreational, to consider the option of a state retail monopoly. And you will know what those are because you live in North Carolina. I grew up in West Virginia. We had a state retail monopoly in alcohol. North Carolina does as well. In general, retail monopolies, that's so the industry still produces the product, but the state sells it, has a better record of hiring diverse employees than do private companies. I mean, that's one of the striking things I've noticed. I live out here next to a lot of venture capital firms that finance this industry. They talk a lot about racial equity, but it's remarkable how almost uniformly white the people who run that industry are. But state retail monopolies do better than that. And that might be a way to promote more equitable employment. Second point is that our experience with alcohol, which we have a lot, is that retail monopolies reduce consumption-related problems. The states that have ABC stores have lower rates of like youth binge drinking, automobile accidents involving alcohol, and so on. So if you decide to go forward, a retail monopoly could give you some public health protections as you move the system out across the state. The last point is that the incentives of profit retailers are to, promote a lot and have 2-for-1 sales and, hype the product and so on. But you don't have that in a state retail monopoly. So that's another way to, if you want to go forward, not have some of the costs that come when a drug gets linked to the pursuit of profit. Last slide, please. Okay, so here's what we know. We already have multiple cannabis-based medicines that have been very well tested and have shown to be effective and are FDA approved, and we're probably going to have more. That's great. It helps sick people. That's very great. At the same time, there's a lot of hype in this area. A lot of therapeutic claims are pretty poorly evidenced, and it's you don't want to get snookered. Second, there is potential for harm in communicating to sick people that cannabis has been carefully evaluated like other medical drugs. If you call a system medical, the average person is going to assume that it's been well tested and that they're safe, just like they would be if they're going to their doctor. So I wouldn't tell you what to do, which way to go, but I'd just say if you do it, make it real so that people can trust what it is they're getting. I point out that, in states that have tried to make a recreational legalization through the medical system by having a super loose system, it has increased disparities and also potentially puts sick people at risk by thinking something is medical when it isn't. And the last point is there are other policies available if the goal is to lower arrest or promote health and equity in hiring. I mentioned decriminalization of possession, as well as the establishing of a retail monopoly. If those are your goals, those are ways to pursue them. Thanks very much for your time, and I look forward to the questions.
Thank you so much, Keith. Really appreciate it. We will now turn to our second speaker, Dr. Steve Wyatt. Steve, the floor is yours. That looks good. Steve, I don't know if you're talking, but we can see your slides, but we can't hear you.
There we go.
There you go.
Thank you. And thank you, Steve, and thanks to the Attorney General's office to allow me as a representative of the NCPA, the North Carolina Psychiatric Association, to give a description of our position paper on cannabis. I have no disclosures, and I'm going to frame my talk on that position paper. So I'm going to speak on decriminalization of cannabis, the evidence supporting cannabis in the treatment of psychiatric illnesses, importantly, the impact on adolescents, and then say a few words on the importance of monitoring THC and CBD concentrations, dosing, and also provider patient education. And lastly, I'll speak to some legislative recommendations. So
hey,
the North Carolina—
Hey, Steve,
yes.
do you want to turn your camera on? We
Sure.
will mostly see your slides, but we will get to see you speaking.
Okay.
There you, yeah. Whoop. There you are. Thank you so much.
All right. So the North Carolina Psychiatric Association is in favor of decriminalization of cannabis. The potential for harm for criminalization certainly outweighs the potential for the risk to actual individuals. At the same time, we fully understand that the product is, particularly in daily use, can be associated with significant harms. I will say that in North Carolina, we have seen an increase in the number of individuals that are smoking marijuana and also the number of people entering treatment for cannabis use disorder. The problem does exist that some of those individuals are successful in getting into recovery and then get back into the community, and the social determinants of health, the difficulties that they experience because of the criminality can really outweigh the difficulties that they can participate in the difficulties of remaining in recovery. So this is something that we're very clear on that we're in favor of decriminalization. In looking at the evidence supporting cannabis in the treatment of psychiatric illnesses, Dr. Humphreys talked about this already somewhat, but in terms of PTSD, there is no conclusive evidence that cannabis is helpful in the treatment of PTSD. There has been evidence of reduction in nightmares, and yet no real improvement in sleep onset, that's to be able to fall asleep and stay asleep successfully. It is sleep that's one of the symptoms of PTSD that contributes to the worsening of an individual's disease. Cannabis also puts some individuals at greater risk of worsening of their symptoms. The intoxication alone can result in them being uncomfortable with their situation in a way that they start to not be able to think through it clearly. Their back can be against the wall, which can contribute to violent behavior. And there's a very clear association between alcohol and other drug use and PTSD, and cannabis has been shown to participate in the worsening of that. Lastly, suicidality. Suicidality, typically we think of the worst and the real severe part of suicidality in successful suicides lasts for about an hour. It's that period of time where a person is just so overwhelmed that they go ahead and act on their suicidality. And any form of intoxication contributes to that. And in this highly vulnerable population to suicide, it's clear that cannabis can make that worse. So clearly, cannabis is not a treatment of PTSD. At the same time, we do understand that the product has been used to relieve symptoms through intoxication for some individuals, but this should be something that the provider really talks to the patient about and helps them understand that the risks of using the product and staying away from regular use that could really cause a worsening of symptoms, that it's not a specific treatment for the disease. In terms of bipolar disorder, there's actually a worsening of depression that's been associated with the use of cannabis and the emergence of psychotic episodes associated with the depression. So the psychotic symptoms associated with bipolar come both during periods of mania, but also during depression. And it is those experiences that are most troubling. They're clear indications of a more severe disease. And this is particularly true in adolescents, where they're trying to figure out these mood swings. Families are trying to figure it out. Is it individuation, or is it an actual disease? And adding cannabis to it only muddles the problem and brings on potential psychotic symptoms earlier in their disease. And it is the earlier onset that actually contributes to the worsening of the disease. There is potential greater risk also of suicidality, which again is a terrible aspect of more severe, untreated, or poorly managed bipolar disorder. This clearly is not a treatment for their disease. In terms of anxiety, there has been limited evidence that there's improvement with cannabidiol, that's CBD, associated with improving symptoms of anxiety. Patients should be counseled on how to use these products most effectively if they're going to. And if the person is going to continue to use cannabis, then there should be some counseling of the fact that if they're going to use a cannabis product, that they would be using CBD. But really, we can only do this if we can have some assurance of the purity of the product. That's the real problem, is so often CBD that's available in the state right now, there's not a close scrutiny over that purity, and that's both impurities that are in the compound, but also greater amounts of THC. There's truly, and Dr. Humphreys brought this up, inadequate trials for or against non-pharmaceutical cannabinoids in treating psychiatric illnesses. And this is associated with the difficulties that the federal government has put on this clinical research. Now, it's blossomed pretty significantly in the last 2 or 3 years, but it's still a Schedule I drug, which means there's no, that had been determined that there's no medicinal use of this drug. And so it has been difficult to do these studies. However, it is interesting that we have now established medical marijuana in 36 states around the country, and we've seen no significant improvement in any psychiatric illnesses in those states. In terms of adolescence, which is a real important part of what we're discussing, the acute effects of cannabis impair learning, impair memory, attention, and motor coordination. And in some, and again, this is anecdotal, but clearly, it's very evident that some people will smoke this product and become very anxious, paranoid, and have cannabis-induced psychosis. It is regular use by adolescents that's most damaging, and relatively, they can have worsening of their psychosocial functioning, that is reduction in academic performance or involvement in extracurricular activities, continuing to do some of the things that they used to enjoy, and a earlier onset of psychiatric symptoms. And again, this truly makes schizophrenia worse, makes bipolar disorder worse. Prior to the young person actually having full brain development, doesn't allow them to be able to understand what's happening to them as clearly as if these illnesses come on later. If there is a threefold increase in the earlier onset with individuals that are using daily, and nearly a fivefold increase in people that are using high potency products on a daily basis. As a result of the neurotoxic effects of regular use, cognitive impairments are seen most prominently in those under 25 while the brain is still developing. And there's the potential for this extending into adulthood, depending again on the age of onset. The earlier they start, the worse the problem potentially is going to be, and the regularity of their use. There's greater potential for subsequent nicotine, alcohol, and other drug use that's worsening the patient's long-term health and social well-being. This is really associated with them starting to experiment with using a drug to find pleasure, and starting to associate with a peer group that is using nicotine and other drugs. So it's not necessarily the gateway drug that anyone that uses marijuana is going to go on to have an opiate use disorder, but it is clearly associated with the advent of the experimentation and the use of other drugs. There can be confounding reasons for this evidence, though a consistent factor is regularity of use at a younger age. The National Academies of Science, Engineering, Medicine evidence regarding health effects of cannabis have shown only modest effects in the improvement of pain. It is thought about as being a third-line substance for pain. It has, in trials, been shown to have primarily only effect or reduction in pain for neuropathic pain, and this has really only been short-term and helping to induce sleep. So they're relaxed enough, they have enough reduction in their pain that it has improved sleep initiation. Patients have reported reduction in spasticity in multiple sclerosis. We haven't seen this objectively, but patients have reported it, and so it's been clear. And then, as Dr. Humphrey said, there are medications now that have been approved by the FDA for Dravet, Lennox-Gastaut syndrome, and tuberculous sclerosis. Really severe childhood epilepsy problems. And then two other problems to induce to help with chemotherapy-induced nausea, appetite stimulation associated and wasting conditions. I will say in the legislation that's currently being looked at, it lists a whole variety of problems, including HIV. And I have to say that's where we've, there's evidence of improving wasting conditions around HIV, but this was years ago in terms prior to us really having good medications to help people from moving on to developing AIDS and this really devastating disease. And the idea that someone would have HIV come into a physician's office, say, I have HIV, I should be eligible for one of these cards. That's the thing that we're trying to avoid, because it can worsen their other problems they may be experiencing. The recommendations that we have around THC, CBD concentrations are associated with the fact that we know that you do need a certain amount of THC in the compound, that is CBD, THC, for there to be effective pain relief. However, studies have shown that if it goes above 10%, we lose that. It's no longer as effective, and it starts to contribute to some of the other problems that people experience. And unfortunately, on the street and in dispensaries around the country, we're looking at levels in the 18 to 20 or above concentrations of THC that are not effective. So we really hope that there'll be some consistent product regulations that will help control this. We also believe that there should be clear product certification and dosing available to providers, so we know what it is what's available and what we should be advising patients to be using. That providers obviously should be well educated to understand the effective concentrations and dosing. There is a universal standard in medicine to do no harm, and we need to warn patients against self-diagnosis, that in the community there would be these ideas that friends and family would say cannabis is going to be helpful for this, that, or the other thing, and neglect getting a good evaluation by a physician and on medications that have been approved by the FDA. Medical treatment should not be recommended to be inhaling any combustible substance, including cannabis, which has clearly shown to have significant respiratory problems, not unlike tobacco products. The exception we make to these considerations would be the use of any form of cannabis by an individual currently in palliative care. Lastly, the North Carolina, we recommend that North Carolina control the retail outlets as similar to what Dr. Humphreys has said. And this could allow store personnel to be educated and the maintenance of their education to be monitored, that we'd be able to maintain an understanding of they would be maintaining the understanding of the importance of controlling the sales and the particularities of the products being sold. We also recommend, which I think is somewhat unique, that this be uploaded into the North Carolina Controlled Substance the prescription monitoring
CSR,
CSR,
Controlled Substance Reporting System.
Thank you. And they would report on what dosing, quantity, and percentage of THC to CBD is sold. This would allow the patient's healthcare provider registered with the prescription monitoring program to have ready access to this information in the same profile as other controlled substance medications. And those submitting the information at the point of distribution would not have access to patient medical information. We also hope that tax revenues made available by the state to the state through the sale of these products would in part be used for prevention, treatment, and research and collection of population data, including public health impact on general and importantly impacts on adolescents. And So we support decriminalization. We're hopeful that these products are well studied and that we can make appropriate recommendations to patients if it's made available as a medication in the state, and that cannabis clearly is a growing problem in the state, and there's concern that establishing medical marijuana could result in the public's and particular adolescents' reduction in understanding the potential for harm associated with cannabis. So thank you very much.
Thank you, Dr. Wyatt. We now turn to our third and final speaker, Eric Sweden, who's going to talk a little bit about some of the law enforcement implications of cannabis. Eric? Looks good.
And there we go. And can you see me now?
Yes.
Here we are. First, thank you for giving me the opportunity to speak briefly about some of the challenges that we are currently seeing and may expect to see in detecting and testing cannabis-impaired drivers. For most who don't know, Department of Health and Human Services actually plays a significant role in the education and testing of impaired drivers here in North Carolina to help keep North Carolinians safe. North Carolina Department of Health and Human Services is the agency that's responsible for credentialing breath and alcohol testing and chemical analysts. Currently, we credential just over 7,000 breath alcohol analysts and 200 blood analysts in our state. On average, we're looking at about 46,000 breath tests and 11,000 blood tests, and that's for drugs and alcohol. DHHS also maintains over 400 breath test instruments at 193 physical locations, and we are also responsible for the oversight of 8 blood labs. So with North Carolina DHHS responsible for training education of law enforcement, we need to look at there's 23,000 law enforcement officers, at least 23,000 law enforcement officers in the state of North Carolina. And we are the agency that's responsible to drive this training and education out across the state. While keeping an eye on some national trends on impaired driving, as well as collisions that are a result of impaired driving, we have really ramped up our training across the state. When we look at the different levels of training that we provide to our law enforcement officers, the first and most basic is standardized field sobriety testing, SFST. This is a 24-hour training program that gives officers the basic tools to detect impairment roadside. The tests that the officers perform include horizontal gaze nystagmus, which is a look at the eyes, walk and turn, and a one-leg stand test, which are our psychophysical tests. Officers must successfully complete this 24-hour training class before they can actually move on to an advanced class. Over the last 5 years, we have conducted 354 basic standardized field sobriety tests, and of over 23,000 police officers in the state, we've trained right at 4,400. We also currently have 220 instructors across the state through the 100 counties. The next level, which is going to be important for drug impaired driving, is an advanced roadside impaired driving enforcement class. This 16-hour class builds on those foundations and provides officers with additional information and additional testing for impairment specific to drugs. Officers must complete this 16-hour program in order to move on to the next level. For A-RIDE, we've conducted over 120 classes over the last 5 years and trained about 1,200 officers. For this class, we have 23 instructors statewide. So this is a little difficult to push out across the state, and we'll talk about that just a little bit more in a minute. The drug evaluation and classification program is a 2-week class where we train officers to conduct a standardized and systematic process to determine if impairment exists. If impairment does exist, is it a medical condition? Is it due to alcohol, or is it due to drugs? And if it's due to drugs, what category or categories of drugs is this person impaired on? Officers who attend this training, our highest level of training in the state, must submit an application to the state to be considered. This application is for an officer who has more than 2 years of law enforcement experience. They need to have completed the standardized field sobriety test, as well as the advanced roadside impaired driving enforcement class. They need to be a chemical analyst for testing of breath. They also need to provide a letter of reference from a currently certified drug recognition expert, a letter of reference from an assistant district attorney in their jurisdiction, as well as a letter of support from their agency. Over the last 5 years, we've conducted 10 of these drug evaluation and classification programs, and North Carolina currently has 166 active drug recognition experts with 23 drug evaluation and classification program instructors. DHHS is the agency responsible for the oversight of all DWI programs, to include the DEC program, which certifies the drug recognition expert, and that person is certified under our full-time state coordinator. The programs that we offer are supported by the National Highway Traffic Safety Administration, the International Associations of Chiefs of Police. We at DHHS make sure that we drive our programs that we offer to law enforcement based on science and research, and not things that maybe we have just done in the past. Specifically to the topic at hand, we're looking at cannabis and THC, tetrahydrocannabinol. So when we look at some of the data that has been pushed out from the National Institute for Occupational Safety and Health, part of the CDC, it says that cannabis can impair coordination, distort perception, cause difficulty in problem solving, and critical driving tasks. When we look at the National Institute for Drug Abuse, it reports that THC can slow reaction times and reduce the ability of the driver to make decisions. And this aspect is where we need to have the training for law enforcement brought up, because as you can see, when an impaired driver has a delay in recognizing the road hazard, then a delay deciding in what action to take to avoid the hazard, and then a delay, even slight, in moving their foot from the gas to the brake, can result in a collision, property damage, injury, fatality. Just at a speed of 45 miles an hour, in 1 second, that car has moved 66 feet for every second that person delays recognizing a hazard or making a decision as to what actions to take. When we look at highway safety, and we look from DHHS perspective to bridge public health and public safety, we need to look across coast to coast at what's going on. Nationally, between 2000 and 2018, that percentage of car crashes involving deaths due to cannabis have doubled. So from 4.8 to 10.3. Now, while these numbers might be low in and of itself, remember that this number is a person. Between 4 and 6% increase in crashes attributed to cannabis as measured by the insurance collision claims. And then over 7-year period between 2007 and 2014, that percentage of nighttime weekend drivers tested positive for THC increased from 8.6 to 12.6%. And that's a large increase when we're looking across the board. Specific to North Carolina, and this is this is directly towards us, just last year in 2021, the North Carolina State Crime Lab found 50%, almost 50% of its DWI blood cases involve THC. The national trend towards combining THC with either other substances and specifically alcohol is increasing car wrecks, damage producing and injury producing in an alarming rate. So when we're looking at detection of impaired driving, currently there is no reliable roadside test device available for law enforcement officers to determine the presence of THC, similar to ones that they use in the street for alcohol. They use a preliminary breath test device to determine if the impairment they're seeing roadside is consistent with an alcohol concentration, and that doesn't exist. While there are some devices that are out there on the market, none have passed a Fry or Daubert hearing in any state. It's for that reason that the roadside psychophysical tests are paramount for the detection of drug impaired drivers. Basic standardized field sobriety tests are limited in what the officers can find for impairment. Those tests that are conducted have an eye test for HGN, but they also have that walk and turn and the one leg stand test. The advanced training class, that 16-hour advanced roadside impaired driving, includes additional information, human behaviors, but also psychophysical tests for officers to determine impairment. The finger to nose test, a modified Romberg balance test, and a lack of convergence test are information specific to drug impaired driving, and they will also give the officer more information for common signs and symptoms of drugs and categories of drugs, in this case specifically due to impairment. Providing the drug evaluation and classification program to more officers will also assist in utilizing both clinical and general indicators of impairment. It'll also rule out medical conditions that show impairment, but then show the impairment due to substances other than alcohol. All of these tests and training for officers are simple tests, and they're easy to administer by that officer, by that trained officer roadside, with the exception of the drug evaluation and classification program, which is going to have to be taken inside for just a little bit. These are relatively easy to administer on the side of the road. All the tests that we conduct are validated. There is science and research behind it, and it shows accurate and reliable indicators of impairment. The research papers that we do have all been peer reviewed, and blood test is currently the preferred method of testing for cannabis. Currently and going forward, with only 8 blood labs and 200 blood analysts in North Carolina, the increase of drug impaired drivers may increase the burden on those labs as we move forward. So what are we looking at for training needs? Currently, there is an issue roadside, and going forward, we expect that to continue. It's necessary for us to provide our law enforcement officers with the training that they don't currently have, but they will need to keep our highways safe. As I said, we've already stepped up training across North Carolina in standardized field sobriety test classes, in advanced roadside impaired driving in classes, and the drug evaluation and classification program. We have been working with North Carolina Training and Standards Commission, and they have put the standardized field sobriety test into basic law enforcement training with their curriculum change for BLET 2023. So beginning in 2024, we're looking at all the officers having that basic training. Currently, we're looking at a cost of $1,700 per standardized field sobriety test class. The advanced skill set is what's needed for the recognition of drug impaired drivers. Those classes are running about $1,000 per class. These are host classes and don't include travel or per diem for state instructors. We also need to look at increasing the number of drug recognition experts across North Carolina. We currently have 166 in 100 counties. And sometimes we're going to fall short with that. The drug evaluation and classification, that 2-week school, runs on average at about $50,000. That class is all encompassed. So that class really includes training materials, instructors, per diems across the state. And then with only 23 instructors, we are looking at increasing the number of instructors across the state. For 23 instructors, most of who have other jobs full-time as law enforcement, we're looking to increase those. About 3 years ago, we changed from 2 instructor schools a year to 3 instructor schools a year in order to meet that need. And Steve, that is what I have for you. Here's my contact information. The next slide will give all the references to the materials that we've presented here in the last couple of minutes.
Thank you so much, Eric. Really appreciate that informative overview. And just so all of the folks who are listening in today know, all of the slides, as well as a recording of the webinar, not just today, but for all 4 webinars, will be available on the same website that you use to register for today's webinar. We now have about 7 minutes for questions. And so, Jasmine, I think that you were trying to keep a tab. Looks like we've had more questions than we'll be able to answer. Did you want to throw out some of the questions we've gotten so far?
Sure. Dr. Humphreys, can you share any major takeaways of the lessons learned in California about regulation of cannabis? What does California wish it had done differently from the start?
That's a great question. So one thing is people underestimated the extent to which a legal system needs enforcement to work. So we still have as big a black market, maybe even larger than we had before legalization. And just underestimated, if you want people to, in any other endeavor, the reason people get licenses is so that they're licensed to do certain things that are otherwise not legal. And that wasn't put into the equation. The second thing is that to have written the medical law to actually be medical, where it basically got turned into any condition that anyone thinks might possibly benefit them. Well, that becomes everything. And that they lost control of the system at that point. Now, for some people, that may have been a good outcome because they really believe that, complete access to cannabis is the best. But if people are concerned about public health, we generally be negative about the way we just totally failed to regulate the medical side.
Thank you. Jasmine?
In states that have decriminalized cannabis, is there data on increased usage rates, especially with younger people?
Can you ask that one more time, Jasmine? I guess that would be for either Keith or Steve, but would you ask that question one more time?
In states that have decriminalized cannabis, is there data on increased usage rates, especially with younger people?
I can say some of that. So, it's important, let's use the terms to just define them. Okay, so decriminalized would mean you don't have an industry, you don't have legal sales, but you are no longer criminally punishing people just for the act of use. And the evidence around that around the world is, yeah, there's probably a little more use, but not much more. Most people don't track the law that carefully, even in criminalization, arrest, even though there are a lot of arrests, so many people use cannabis, the relative risk for any person is low. So perhaps a little higher, but certainly not a lot higher from decriminalization. Legalization, on the other hand, you create companies selling it, promoting it. Yeah, then you're going to get a lot more cannabis use.
Thank you. Jasmine?
Dr. Wyatt, can you say more about the evidence on the use of CBD to treat anxiety? Any clinical trials, and if so, were they controlled for what you refer to as the purity of the product? Is anyone in North Carolina testing CBD for purity, and how is that defined?
I don't actually have an answer to how it's, my understanding, it's not, there is some control over how the product is made, but not necessarily is every product that's being sold in North Carolina as CBD. Do we know the purity of the product? And again, there have been reports of other substances being in it that could be harmful to individuals, along with higher levels of acceptable THC. In terms of CBD is an interesting cannabinoid. it actually does not cause significant intoxication. It's not associated with the sort of what could be psychotic episodes. It actually is being looked at as a potential medication for psychotic illnesses because it has some ability to reduce positive symptoms of schizophrenia or other psychotic illnesses. And along with that, there has been evidence, and I could offline, I can send you some evidence of the fact that it has been helpful for some anxiety. But again, this isn't the THC CBD product. This is CBD alone that there's this evidence. It has not, to my knowledge, there's not a company that's actually applied for the use of this for anxiety, but Dr. Humphreys may know differently.
Okay. Jasmine, next question.
What are the potential harms of daily cannabis use?
I pointed out a variety of things. The primary problem really, there's a few different things that take place, and not only is it bathing the brain with a substance that changes a person's perception on a regular basis, and I'm talking about THC. At the same time, it is associated with more isolation. It's not a drug that people typically see or use as, it's not a stimulant. It doesn't, unlike alcohol, that can be very engaging with individuals, at least while people are getting intoxicated. And that's another interesting thing about alcohol, that it's more joyful or engaging as people have rising levels of alcohol in their system, and then it becomes more dysphoric and becomes more uncomfortable as they're tapering off whatever level of alcohol. Marijuana does not necessarily do that. Marijuana is a more interoceptive drug that people will kind of zone out and enjoy a specific something. But if they do that regularly, there's less communication with others that can really impair the individual's ability to stay focused, to really bounce ideas off another individual in a way that helps them from moving into a worsening problem. Again, in adolescence, we've clearly seen a reduction in academic performance and involvement in activities that they once enjoyed, and start using a drug to find other ways to find enjoyment.
Thank you for that. And I'm afraid we are out of time. As a reminder, though, this is just the beginning of a 4-part webinar series. Next week, again, we talk about regulatory, sales, and taxation issues on the 25th. April 1st is growing and processing cannabis, and April 8th is racial equity issues that we just scratched the surface of today. So I want to thank all of you who have taken time out of your busy days to be with us today. And I especially want to thank our 3 fantastic panelists for all of your time and expertise. So I hope that everyone has a good Friday afternoon and a good weekend. Thank you all.
Thank you.